So thank you very much for giving me the opportunity to present this very, very narrow topic, that is the Spanish perspective of cancer research. Well, it's not a very easy topic, but I will try to do my best. Let me see. And guide you through what cancer is, what do we do in the National Cancer Research Center, and what are the chances for our biobank to provide and help researchers in this topic. So it's not much to say that you don't know already about cancer, but according to NCI, is a term for diseases in which abnormal cells divide with a control and can invade nearby tissues. These cancer cells can also spread to other parts of the body through the blood and limb systems. And several years ago, it was a fantastic summary of the hallmarks of cancer. So you can see in this figure that one of these hallmarks is the sustaining of proliferative signaling. I mean, evading growth suppressors. They can't stop growing, as it was mentioned in the definition. They can activate and go spread, invasion, and metastasis. They are enabled to replicate immortality. They induce angiogenesis. So, of course, there's more vessels to feed the tumor. And they don't want to commit suicide. They don't want to die as other cells do in the system. The types of cancer in a global way that we can summarize, they are called regarding the site, I mean, which kind of organism is invading. So a normal carcinoma is just skin or tissue in internal organs, whereas a sarcoma appears in bone, cartilage, fat, muscle, blood vessels, or connective and supportive tissues. Leukemia, as most of you know, is a blood-forming cancer, and as well as lymphoma, multiple myeloma happens in cells of the immune system. And in some of the classifications don't talk about the central nervous system cancers, but I think we saw yesterday that the brain and the spinal cord has also the chance to get this uncontrolled growth. So just to give you an overview of where the situation was 2 years ago and will be in the 22 years, I must say that, of course, as you heard, probably the incidence of cancer will increase. Now, 1 out of 3 persons suffer from cancer. In the future, it will be 2 of 3 people. And we'll see why. One of the main factors that I'll summarize in a couple of seconds is aging. We live longer. So, but here the key is how the mortality will go. And it seems that 2 years ago, the mortality, this is in the world, was 9.5 million. And in 22 years, it's expected to be 60 million. But these numbers are based off new cases. I mean, no mortality, but of course, probably, and I'm sure it will happen, more people will get cured. We will have better drugs, or at least we will chronify the disease. So the general risk factors for just suffering or getting this uncontrolled growth, the tumor, cancer, is radiation. As you know, we all recommend you guys, especially as our Scandinavian friends, know to enjoy so much the sun when you come down to the southern part of Europe, because the UV lights from the sun is one of these factors. It's the same about age, as I mentioned before, the exposure to chemicals, alcohol consumption, some viral infections as the human papilloma virus or hepatitis C virus or hepatitis B, and so on and so forth. Of course, smoking, overweight leading to obesity, and history in the family of cancer. So what are the numbers in Europe? As you see, this is a distribution. This little map is the distribution of incidence in cases out of 100,000 people. As you see, colleagues of Denmark, you're not doing very well in incidence and mortality of cancer, especially in incidence, as well as other countries such as Netherlands, Belgium, Cyprus, and so on. Here in Spain, and also our friends from Finland and Sweden are doing much better than the European average. And in Spain, the incidence is around 550 cases per 100,000 individuals. If you see the overall distribution of these cancers, the leading pathology is prostate cancer in males. I mean, the reasons could vary from bad oncogenic markers. I mean, PCAs is not one of the best oncogenic biomarker, although it gives some kind of clue. Also could be some kind of resistance to men to go and be checked. But I mean, nothing that we can, it's not more than assumptions that a clear analysis of the situation, followed by breast cancer, and the third is colorectal cancer. So the organ-specific cancer incidence and mortality in Spain, I mean, as you see, our top one is, if we just don't divide gender-wise, is colorectal cancer. And probably this is linked to the main factor, that is we live longer. We live longer, and this is proved by the fact that the Spanish population is the 7th in the lifespan expectancy in the world, with an average of nearly 84 years. Of course, this could be linked to many other factors such as obesity, alcohol consumption, and still smoking. And here in Spain, we saw a clear increase in women in lung cancer, whereas it has decreased in men because women started to copy the bad habits of men later. So where did I get this source? Well, the source for cancer are coming from the Spanish Society for Medical Oncology, and they are fed by Cancer Today, the World Health Organization, the European Cancer Information System, and our Spanish network for cancer registries. But we don't have cancer registries for all the 50 provinces or at a regional level. And we have, as you know, or probably some of you know, 17 autonomous regions. Is more or less like the Länder in Germany. So we have a very, very biased information together. And this is something that Aro and other colleagues mentioned yesterday. In contrast with the Scandinavian system, we don't have a unique ID number. We have our ID number, and sorry for this, I mean, I'm being a little bit of self-centered. This is my Spanish ID document, whereas my number is given at birth. Well, at the birth is not true either. It's given when you, it's compulsory when you're 14. You could survive without any number until you're registered at the age of 14. But then when you start working, you get your social security number, which doesn't correlate, as you can see. It starts with 28, which is the Madrid province code. And my DNI, if you see there, it starts with 0083. So there's a lack of sharing of information from healthcare records, but not even at within the autonomous regions. I mean, at the national level. Also, in many of the regions, they don't communicate even between hospitals. So it's quite complicated to gather information. So how is the Spanish perspective on cancer research? Well, as one of my colleagues said the other day when I was telling him my topic, he said, just put a slide that is fully black and say this is our future. Well, it is a kind of interpretation. I wouldn't say that is black. I wouldn't say that is quite different. And it's different because We have some excellent centers, and the center, this monographic center where I work, the Spanish National Center for Cancer Research, is an excellent center to do scientific research on cancer. And we are based on science, best science outcome for our best strategy. And this is organized with excellence research, is an international cancer research center. So for example, we speak in English, everything is, all lectures are done in English, which is quite rare in Spain. We are based in innovation. We have an innovation office that transfer knowledge from the center to spin-offs if that's needed. By patient-oriented research, we have a clinical unit, and we have a tight collaboration with several hospitals. We also revert and work in a tight manner with the society. And of course, we have education, as you can see today. I'm going to go far. This is a bit of showing off. So we are the 9th in the rank for the CNIO journal ranking for monographic cancer research centers in the world. We are the 2nd at the European level. And we are the 7th in the world ranking position for the Nature Index. So in Spain, we are the first, and as you see these little medals, this is the Excellence Alliance. It's given to excellence research centers, and we are the first in this ranking. So how we organize, this is a general organization. As you see, it was a reorganization when I moved back to Spain. So now we are hanging into the 4 big pillars, that is basic research, translational research, innovation, and then is the biobank. And just diving a little bit about the organizations of biobanks in Spain, I must say that for the authorization of our biobank, the requirements is to have these actors. There is the holder, that is the research center, myself as a scientific director, someone that is responsible for the data file, and then we have the research ethic committee and the biobank scientific committee that are external to the biobank. But this is what we need to have an authorized biobank. We were authorized in 2013. So as I mentioned in the PhD course, for you that are not part of this PhD course, a biobank is supported by 3 main pillars. There are sample quality, ethical, legal, and societal issues, and the IT management. Here is our organization. As you see, we are 5 people, and they are divided. I would like to introduce you Maria Jesus Artiga, who is taking part of the operative part and information from the biobank, working tightly with the technical assistant, Inmaculada Almenara. Our quality man is Francisco de Luna, and the ethical and legal societal issues are handled by Nuria Ajenjo. So we don't have many samples, and most of them are before the Spanish Biomedical Research Act. So we have mainly paraffin-embedded tissues collected in 6 different collections, distributed in these 6 different collections, and we have something unique, that is a xenograph, PDX collection, and a new COVID collection with DNA, PBMCs, and so on and so forth. As I mentioned, sample quality is absolutely compulsory for biobanks, and we have some projects. We have a project going on that is called Optimark for just checking potential biomarkers for quality, sample quality within fresh frozen tissues and paraffin-embedded tissues, formalin-fixed paraffin-embedded tissues, because the lack of standardization in the collection and storage of medical specimens can hinder subsequent research. So if we compare apples with pear and we put rabbits in, we will get rabbits out. So I'm not going to go through, but this is our ethical legal frame. We have in 2007, the Act, the Biomedical Research Act came in force. Then we have the Royal Decree for Authorization and Operation of Biobanks Treatment of Biological Samples of Human Origin. We have a National Registry of Biobanks for biomedical research, but you will see not all the samples are recorded, only those in some of the different conditions. I will let you know a little bit more. And so on the data protection and everything that you can imagine. So, of course, for us, the key here, and for you all, unless that you have the opt-out system, as we saw in Denmark, the informed consent is the key tool for biomedical research. We can't do anything if the patient doesn't agree to this consent, and this informed consent has to have an information leaflet. I mean, they need to know what they signed for. It's not that we've got a signed consent. We want an informed consent. We have the obligation to make the donor know what is going on, what the future use of the sample will be. So here in Spain, Portugal, and Germany, the donor maintain the ownership of the sample. So these sources of human biological material in Spain can come in 3 different scenarios. So a researcher can just start their own project. And then, of course, they need always to pass an ethical assessment. But this collection has a time restriction, and they cannot send the samples to anyone. It's just only for their project. Then we have the collections that they need to register, in contrary to the project, to the National Registry, the Biobank Registry. Of course, the ethics committee is in place as well. They don't need to be authorized like the others, administratively speaking. They are part of maybe collaboration, so they can transfer only these samples to these people that are reflected in their collection or project, and the time restriction is unlimited. Then we have the legal frame that is the biobank. And the biobank, of course, is registered. I mean, has all the collection registered in the National Registry. We have, of course, all the ethics committees and scientific committees. We don't have any restrictions in time or research, and we can send the samples to the third party use. So AT management, there you are. We have a LIMS system in place following the regulation of the European Union. And this is our ecosystem, and the ecosystem is shared by probably all the biobanks. We have to work in an economic framework, in a social framework with the donors, patients, patient associations. Just get, as you can imagine, and we will move forward to this point, we have to get in touch with hospitals and clinicians, researchers. We have a scientific technical framework, and we have also an institutional and framework. So our activities, just to go really quick, because I think time is getting close. We do sample management in a project-driven research collections. We do quality assurance research ourselves with some quality, as I mentioned, quality sample quality projects, disseminations. We have also a help desk, a biobank help desk, when you can just go in and ask if you have doubts how biobanks work. This is open to the society as well as to researchers and other people that are interested. And of course, we give ethical and legal support to our researchers. Our pilots, transparency and accountability, access to human samples for research, quality assurance, research, innovation, and education, and ethical and legal issues. But now, I mean, we have a problem, of course. We are a research center, and as Aaron mentioned in his fantastic talk in the PhD course, and I said several times, samples are power, equal power. So if we want to get samples, tissue samples, we have to get into agreements with hospitals for getting these tissues, solid tissues, and this is our main bottleneck, because it's complicated. One of the reasons is because they have their own biobanks. Other reasons could be a little bit more of a discussion, and some of the researchers here don't want to include a surgeon into their papers just because they got a sample, a tumor out of a patient, considering that they had to do it anyway, they were paid. So we have a little bit of a but to get these solid tumors, and agreements are not so easy. So then we have to rethink our strategy in a way that we could get samples and increase and encourage collaboration. So in the new open call, national open call, we sent our application based on 3 main projects. One that is our little baby is the National Network from Brain Metastasis called RENACER. For you, RENACER doesn't mean much, but in Spanish means reborn, which is what it will happen if we manage to get treatment for these patients. Then we are going to start long prospective cohorts, and we are going to exploit the PDX biobank collection. So just in summary, the National Network from Brain Metastasis account now with the participation. We managed to get the commitment of 10 different hospitals at the national level. So we will get the CNIO Biobank will be the receptor biobank for this collection, and we will get frozen tissue, fixed tissue, and fresh tissue for different approaches, one for molecular characterization, tissue characterization, and then the fresh tissue for developing organoids and narrowing down potential drugs using a platform, a MET platform. And all this project is in collaboration with the Brain Metastasis Unit and with Manuel Valiente, who is a very talented researcher with a very open view and vision of biobanks. So then we will do different techniques, approaches to just get in an initial cohort potential drugs that they will be tested later on in the MET platform again and at the hospital. Then we are going to start collecting samples quite soon from the Spanish Flight Attendant Association and the Spanish Pilot Association. I mean, this group of people seem to have a very high mortality. I mean, they claim, or their union claim, to be around 50 years old. But this data is not confirmed on the literature. I couldn't find anything. They are some observational studies, but they seem to suffer from a wide range of diseases. So this collection, apart from sampling everything that is possible, will allow us to start a new project that is the establishment of a liquid biopsy collection. Why? Well, one of the reasons is because we could get our own sample extraction center. You don't need to get agreement with hospitals. And of course, because I think it could be the sample of the future. It will allow us to do a screening for presence of disease, patient stratification, and therapy selection, where it's called companion diagnosis, monitoring treatment response and drug resistance, and also detection of minimal residual disease after surgery recurrence. And then last but not least, and this is, I think, one of my last slides, is the exploiting, we are going to exploit the PDX biobank collection. This is a very long story, but to make it short, in 2018, I believe, a huge collection of 200 models from different primary tissues of xenografts were reverted, or were, they reverted to the biobank. The ethical research committee allowed us to do that because we didn't have in our power the consent. But of course, since we didn't have the consent of the donors, we have to anonymize of the sample. So this collection is great, but it's lacking some of the main information that we needed to get the right value for scientific process. So we asked for money to, of course, manage the collection and try to do a panel of cancer genes, genes included in cancer, and what we call recharacterization and expansion of this collection. Of course, we have some of the models that are already literature. Those models are public, the data is public, so of course we can provide researchers with those models. The collection is, as the ethical committee asked, is recodified and is fully anonymized. But we want to exploit, because it's a great source of material, this PDX biobank collection. So I don't want to take more of the time from the next speaker. So I want to acknowledge all the people that are always helping and supporting. And my colleagues for the Biobank are at the top. I couldn't wish for a better team. They are so good doing what they do, and they are always so happy. That make my life easy and very pleasurable. And also I want to say thank you to our ethical committee. We have great discussions every month about different topics. And thanks to this, we started a new ethical working group for organoids, even including one of our former students, Saro, Melanie from BBMRI Eric, who is helping us to develop this and just to do brainstorm about this topic. Then to our scientific biobank committee, and also to our data protection officer, who is guiding us in how to do the things in a right way regarding information. So thank you very much for your attention, and I hope you have, well, I hope that everything was clear, but if you have some questions, I welcome to answer them. Thank you.